right, late. Sorry about that. Been out about a little bit and been doing a bit of jiggery pokery, so I'm a little bit late tonight. And there's loads of questions. It's almost like this thing has got popular. I don't know what's going on. I'm normally having to drag out the questions or at least drag out the answers. But you know what? Tonight I think I'll have to go for it because I've got loads of questions. And I hope that I get more questions. So feel free to ask questions live if you feel the need. But I'm hoping I've kept track of all the questions we've had this week, and I answer them all. I hope I don't miss anyone out and get anyone be offended. But what's that you say? What is this? Well, I'll tell you what this is. This is every Tuesday at 7 p.m. Well, 7 p.m. ish. Live Q&A with yours truly, Jonathan Stiano, consultant plastic surgeon. If you have anything to say, please comment. And if you don't have anything to say, please share. And even if you do have something to say, please comment and share. So sharing goes for everyone. Commenting goes just for those people who want to comment. So comment and share, share and comment. Oh, my Lord alive. Please don't tell me. Oh, thank goodness for that. Oh, my God. I thought I didn't save that agenda. Oh, wow. That is save. I'm going to save that, guys, right now, because I have just spent half an hour putting more questions in. Gemma, pick up yourself. Hello, how you doing? You got any questions? Chip yourself right in here because I'll be happy to answer them. But we're cracking on with this question here, which is, do patients need to sign an agreement for a blood transfusion for surgery? So, a good question that. Oh, by the way, someone else, it wasn't this patient, but someone else said about being anonymous and they want to be anonymous. Everyone's anonymous. My default position is anonymity. It's very, this isn't going to go well if I can't think of the words. It's very sort of personal, this sort of surgery that I do. In fact, most doctors do. So we're all hi Steph, you know. So we're all very aware that not everybody wants to people to know. So my default position is that everything anonymous and all these questions are anonymous, and I don't mention any names or anything. If people want to chip in and say thank you, sort of implying I was answering their questions, sort of thing, that's up to them. But if you want to just quietly just hear my answer to your question and not put out who you are and that you've asked a question, I'm never going to say, oh, this is a question from so and so. So just so everything's anonymous because it's just safer to be that way. I don't want to upset anyone. So this anonymous question has come in from an anonymous individual saying, do you have an signed agreement for blood transfusion for surgery? So that is there are some people right. So I don't normally talk much about blood transfusions for surgery, certainly for the surgeries that I do, because blood transfusions are very rarely needed for any operation that I do. To be honest with you, it's extremely rare to need a blood transfusion. Maybe something like a large breast reduction, possibly a tummy tuck, particularly if you had a complication like a hematoma, you might possibly need a blood transfusion. But in those circumstances, they are usually because you feel a bit weak and wobbly a couple of days after surgery, and you would feel better quicker by having a blood transfusion. So it's very rare to sort of need an emergency blood transfusion for cosmetic surgery. There's no operation that I do that we've ever needed that. And it's, as I say, it's usually something that comes a bit later on. And if you said to me you don't want it and you'd rather it got better on its own, you can do that. You probably take a few months for it to get better on its own, whereas a blood transfusion could make it come back much more quickly. But that is the situation for blood transfusions and cosmetic surgery. I'm thinking this question is specifically asked because the patient doesn't want a blood transfusion. So there are individuals, particularly Jehovah's Witnesses and things, who don't want a blood transfusion. And in those circumstances where you specifically don't want a blood transfusion, there is a form to sign, an agreement to sign to say that you don't want one. So we'd have a discussion about that and what that would really come down to, that if you were going to die, if you didn't have the transfusion, would you would you rather that would happen, or would you allow us to give you a blood transfusion if it was a life and death situation? And we would have that discussion with you. As I say, never say never. It's never happened. You know, it could happen, I guess, conceivably for an operation. So I suppose it's good. It's good. Well, not I suppose it is good to have that conversation if you are adamant that you don't want a blood transfusion. But what we would say to you is that look, we don't give blood transfusions to people um, sort of just willy nilly. And if you wanted to make it clear you didn't want one, we would then say to you, well, okay, we won't give you one, but what if it was in a life and death situation? And you might say still, even in a life and death situation, I don't want a blood transfusion. In which case, you can sign that form, and then as long as we're all comfortable with that, and we have been in that situation before where people have signed that form, and that's their decision, and that's fine. And as I say, it's so unlikely to happen anyway for any sort of cosmetic procedures, but it's something to be aware of pre op and get that sorted out pre op. I think this patient's asking because they got cancelled or got turned down from someone else because they said they wouldn't allow them not to have a blood transfusion. So maybe everyone's different, but that's my view. And we'd have a discussion with the anaesthetist, and we have done pretty big operations on people who have decided not to have a blood transfusion. Well, I say pretty big. I'm just thinking about a tummy tuck and things like that. So it's a very big operation. So I turn my back and I look back, and there's goodness knows what's going on here. What have we got? Gemma's. Oh, we saw that one. Hello. Hi, Steph. Hi, Rachel. Look at this. D. Good God. Gemma's now saying hello to Rachel on the chat. My God, people are talking to each other. Danielle, what are you doing, Danielle? You laughing already? What's happened? Sorry, I sent that by accident. Oh, right. Okay, that's what's happening. Hi, Mr. Butt. Oh, here we go. Mr. Butt. MR is not a traditional abbreviation. All right, so perfectly within my rights to think that was Mr. Butt. But anyway, go. I've got time to hang about here, girls. Right, we've got to get going. Like to know the this. I'm not sure how well this one works for the Facebook Live because someone's asked if their tattoo is suitable for excision, and Lucy's put it in my list here. So I really probably need to show you the photo of the tattoo to make it for public consumption. But maybe so the answer is yes. I think it is. It's not in a great place. It's up here. It's like a line up here of words. So the thing about the tattoo excision, you've got to think you don't like your tattoo maybe because of where it is and maybe where your bikini and people see it. You can have a scar in the same place, and that's not a great place for a scar. So that's the thing to think about. Think, oh, I don't like this tattoo, I want to get rid of it. If I get rid of it by excision, I'm going to give you a big long scar. So that's not a great place for a scar. So that's the only thing I'd say. And some of the big italic letters I think might not come out in one go. So you'll end up with a scar with a bit of ink on either side of the scar. If you wanted that ink removed, then at least 3 months later, probably 3 to 6 months later, you could always go back and have that bit of ink removed. But yeah, that's one thing to consider. That would leave you a scar. So I normally say to people, look, try. I think this tattoo is black. Oh, it's just there. Yeah, it is black. So you could try laser and things because laser maybe might be a better option potentially. But yeah, let's get on. Come on, question two. Question two is that was question two. Question three: do we offer punch excision for burn scars? Not sure what that means. Burn scars. Well, it's a bit funny when you're talking about excision for scars because excision is going to cause a scar. Usually punch excisions are for things like the acne scars, but I guess it's sort of like ice pick scars. They're called like little dents. So I guess a burn scar could be a dent. So do we, and punch excisions is just little circular sort of blade which cuts a circle out. So we can cut dented scars out. Yeah, we can. And then, but it will leave you with a scar, and you've got to hope the scar doesn't dent in and is better than the original scar. Yeah, we can do that. We can do that, but it might dent in again. But yeah, we can do that. Yep. Do we? Do we do fat transfer to the buttocks? No. Do a lot of fat transfer, but well, actually, I don't do that much transfer. I don't know why I said that. I don't do much. I used to do a lot. Used to do loads, but fat transfer to the buttocks is there's been a lot in the press about it and getting fat embolus into big blood vessels that are there and fatalities, people dying and all sorts. So it's something that that we don't do. I went to a meeting just gone in last week. What day is it today? Yeah, last week, and in Brussels, and they're talking about buttock implants, which was very interesting. It was very interesting to see that meeting. They do say the dangerous time to go to have surgery is after people come back from meetings because everyone wants to try the new things. Don't worry, I'm not going to try buttock implants, but I was almost sort of tempted. But I thought maybe it's something we need to offer at my clinic. I'm trying to expand up the clinic now. I'm trying to scale the clinic now and make it more than just about me. So I'm getting other surgeons in and things, and so thinking more about that. Think, well, maybe we should be offering that sort of thing. As I said, I don't think it'll be me. The whole thing about the clinic is having specialists doing stuff, but maybe Mr. Butt could help me on that. Maybe we should think about that. But the answer is to your question is no, we don't do it at the moment. So no, and I don't really know anyone does do it either. We were talking about this at the meeting. I think particularly and with implants, I think it's not really been anyone certainly in this country has really embraced it and really made it a thing. So unfortunately, I haven't really got anyone that I can suggest to you to does specialize it and does have expertise in it. So yeah. D, good God. Nikki, hello, nice to see you. Question 5, and by the way, I have got, wait for it, 17. Awesome. That's not to mention the questions I'm going to get coming in live, hopefully. 5, how long do you need to wait after consultation before having surgery, and why? So, just looking for the real. Rachel's in with a question. Come on. So, how long? Which way? Oh, I'm looking at my main, because I haven't been able to get all of it on. Sometimes there's more to that. No, there's no more to that question. That is the question. Right. Depends what it is. So we do see and treat clinics for moles, cysts, minor ops, which can be done under local anaesthetic at the clinic. So then you don't have to wait any time after consultation. You can have a consultation, have it removed, have your mole removed, your cyst, your split earlobe, your inverted nipple, areolar reduction, things like that under local anaesthetic we do see and treat. So you can come and have it done at the same time. They're what we would call minor procedures. I know there's no such thing as a minor procedure because everything's major in the patient's eyes, but they're under local anaesthetic and they're sort of slightly less invasive. So there's no waiting list on those. If you want to have it done as a see and treat, you can do that as a see and treat, but you have to book it before. You have to book the appointment as a see and treat before. But I suspect this is talking more about the general anaesthetic cases, tummy tucks, breast reductions, breast implants, stuff like that. So 2 points. Number 1 point is that BARPS, the British Association of Aesthetic Plastic Surgeons, of which I'm a member, and everyone at the clinic is either BARPS or BAPRAS members. You've got to look for your surgeon to be a member of these sorts of associations, because if you're a member of these sorts of associations, you're bound by a code of conduct, and which means that if I or any of us do something that you deem to be unethical, or sort of against, you don't think it's very good, for one of a better way of saying it, you can you complain or report us to BARPS, and we will, because we are held to account to work to a certain standard. And one of the BARPS criteria are that you have to give it at least a 2-week cooling off period, like a credit card. So you can't have surgery within 2 weeks. So that's a definite. You've got to wait 2 weeks for the general anaesthetic cases. The other thing you've got to think about is where we can fit it in the diary, because often we can't fit it in within 2 weeks. And also, these are all big ops. You shouldn't really be having it too soon. You've got to think about stuff, because I know there's the internet. You can do all your research on the internet, but we might say something to you that you might have not thought about it, or we'll tell you all the complications, all the bad things that happen. You need to have time to digest that and think about whether surgery is right for you. So 2 weeks is the minimum, but we encourage you to take as long as you want, and certainly longer than that, and come back for a second consultation and things like that. And the why thing is so you have time to consider it. Next question. Oh, we've got some questions live. Sorry, I will. Oh, when preparing the muscle joint, is it possible the muscle can be prepared too tight, which causes pain 1 year post on, so can be put right after your case of after? Oh, look at that. Right. Oh, my Lord, alive, Gemma. Woohoo! Woo! Look at this. We're cooking. We are cooking. I'm going to do this one because I put it on screen. Then I'm going to go to Rachel. I feel like I'm in a sort of like. Then I'm going to go to you, Rachel, and then you, Ruth, and then you, Gemma, and then we're going to back to question. Where am I? I'm on question. Tell me that's question 6. So when we do that, then I'm going to go do yours, and then I go back to question 7. So question 6 is tummy tuck stroke abdominoplasty with a high BMI. Can this be done? It can be done, but it's not advisable to be done because we normally work on a BMI of 30. Several reasons for this. First of all, if your BMI is over 30, your risk of complications is higher. But it's not like a magical thing happens at 30. But generally speaking, the higher your BMI, the greater your risk of complications. So from a medical point of view, it's better to have a lower BMI to reduce your risk of complications. Things like wound healing problems, pneumonias, DVTs, all these sorts of things are less if you have a lower BMI. But the other thing, which is something which is sort of that I would really worry about, is if you say to people, look, do you want to lose weight? They're like, yeah, I want to lose weight, but I've got this big tummy and I can't lose weight. And if I can get my tummy sorted out, then I'll be able to get exercise better and go to the gym better. I understand that. But the reason you need a tummy tuck, or the reason people need a tummy tuck, is because that skin has been stretched. And the things that stretch are either pregnancy or putting on weight. Put on weight, it all gets stretched. You lose weight, the stretching force goes, you're left with all this redundant skin. And a tummy tuck tightens all that skin. So if you're like, oh, I can't lose weight because I've got this big tummy tuck piece here, you can do the tummy tuck fine. But then if you lose weight after you've had your tummy tuck, you might get more redundant skin there, which I could have made tighter if you had lost the weight first. So it's always best to lose weight first. So you might think, oh, please, doctor, do me a favor and do it now. Well, because I can't lose any more weight. Actually, we'd be doing you a disservice by doing that because you get a better result, less risk of complications if you can get your weight down. Now, the problem sometimes comes when people have lost a significant amount of weight. They've had a BMI of 45 and they've got it down to 35 or 33 or something like that. So it's still above 30, but they've lost like 10 BMI points or something, which is a huge BMI, a huge weight loss. So sometimes we do operate on people with a BMI higher than 30 because they say, look, I've lost a huge amount of weight. I'm not going to be able to lose any more. And I'm comfortable with my weight now. I'm stable with my weight now, but I want to get rid of this apron. And we'll have the conversation with them. And so we do it sometimes with BMI over 30, but the advice is always best to wait if you can wait. High BMI, can this be done? That was question 6. Okay, so Rachel, I said to go to you, Rachel. Rachel, what you got? When repairing the muscle during tummy tuck, is it possible the muscle can be read too tight, which causes pain 1 year post-op? And if so, can it be put right? Good question. God, that's a good question, that is. Well, the 1 year, well, is it possible the muscle can be read too tight? Well, yeah, and be painful. Yes, it is painful and it can be quite tight and it can cause problems. But 1 year, no. I don't think 1 year. I think that's unlikely, Rachel. And I would worry that something else is going. So certainly in the immediate post-operative period, it is painful. And you could argue, well, that's a bit too tight. But it gives. Everything gives. That's how we work. That's how we operate in plastic surgery. We make everything really tight, and then 3 months later it gives and we can do stuff again. That's why you can do serial excision of big tattoos. That's why you can tissue expand a scalp with a big balloon and stitch and blow it up because it's really tight to start off with, and then 3 weeks or a week later you can blow it up even more. So everything gives. So a year post-op, I don't think that would be due to the tightness, Rachel. I think it would be more due to something else that would worry me. And then there's 2 things I'd be thinking of. Number 1 thing I'd be thinking of is, have you got abdominal pain for another reason? Are you putting it down to your tummy tuck and the muscle repair? But is there something else going in your tummy? Gallstones, renal colic, I don't know. The GP might be able to help you with that. And the other thing is, if it is related to tummy tuck, you say, look, as soon as I had the tummy tuck, it was there, and I didn't have it before, and it's definitely related to tummy tuck. Have they caught a nerve or something with that repair, or is there, is it nerve type pain? Is there something that's been caught in it, or something more functional, rather than just being too tight? I think being too tight is unlikely, but something might have been caught, and it should have scarred up. So can it be put right? Well, I think the thing to put it right would be to take that stitch out. Depends on what stitch you've had used. I use sometimes I use a permanent, sometimes I use a dissolvable suture. The dissolvable suture takes a long time to dissolve. But if you had a dissolvable suture a year ago, there'd probably be nothing there. If you've got a permanent suture, it might be possible to go back and take that permanent suture out, just in case it is catching something. It's quite a big job, to be honest, because you probably have to quite open quite a lot of your scar, and because the suture goes right up to your breastbone, so that's quite a big job. And I'd maybe think about seeing a pain specialist or something before then, perhaps, or first of all see your GP to see if there's any other reason for your pain. But then, yeah, maybe a pain specialist just to be checked that there's nothing that we can exclude first before doing some big surgery to take the stitch out and then maybe not having any effect. So that's sorry to hear that, Rachel. If you're having pain a year post-op, that's pretty bad. Yeah, and the advice is always go to your original surgeon, Rachel. They know what they've done. They know where the stitches are, what sort of stitches they've used. So, yeah, good luck. Johanna, hi. Ruth, are you okay to fly after 6 months having breast implants? Yes. A lot of people have breast implants, people who work on aeroplanes, cabin crew and things like that. So that's absolutely fine. People have this, there's a bit of a myth really about flying and diving and the pressure and all that. The cabin's pressurized, absolutely fine. The main thing about flying is as long as everything's healed and what have you. The scars might be a bit red. Maybe at 6 months you've got to be a bit careful with having it in the sun, but certainly flying is fine. Yeah, Ruth, no problem at all with that. Gemma, how complex is it to move a nipple that has been placed too high after a breast lift, and how long after the original surgery should you wait to have it rectified? Gemma, this is I won't say everyone's, because but this is a nightmare. This is a nightmare. And putting a nipple too high is, maybe it's a bit harsh to say, a nightmare, but really bad news. It doesn't look good, especially if it's peeping up over the bra. It's a real problem, and that's a bad thing. So that's, there's things that when we're doing surgery, when we're doing breast lifts, breast reductions, or say we, particularly me, but one of the things I really worry about is the position of the nipple. And I think that is crucial. And the main thing is don't put it high, put it low, fine. If you put it low, oh, I think they're still a bit droopy and they don't look very good or whatever, can sort of live with that. You put it high, looks weird, and it can poke up above your bra. So it's a bad thing. So I'm sorry, Gemma, it's a complex thing to do, because when you move a nipple, you leave a scar where it was. So when the nipple's low, you can move it up and you leave a vertical scar below it. But that's okay because it's hidden underneath the bra. If the nipple is visible with a bra on, and you lower the nipple, you will leave a scar where the nipple was. So you have a nipple with a scar going above it. So there'll be a scar there. So that's why it's a problem, because it leaves a scar where the nipple was. It depends. So there's a couple of things. Gemma, it's tricky. It's a tricky thing. How complex it is complex. One thing you could try and do, you could try and make an ellipse. Not you, surgeon. You could try and make an ellipse and cinch it down to bring it down, and keeping just a circumareolar scar. It might elongate the nipple so it makes it into an oblong shape, and it might not bring it down enough. The other thing you've got to look at is you've got to look at the geometry of the breast. Sometimes have you got implant? Oh, you had a breast lift. Okay. So sometimes if the inframammary fold, or certainly if you've got implants in, if that's too low, it can make the nipple look too high, and vice versa. If the implant's too high, it can make the nipple look too low. I know you haven't got an implant, but just looking at the geometry of the breast, if the inframammary fold was brought up higher, could that make the nipple be in the same place and look okay? Does that make sense? So it's a complex problem, Gemma, and it's something you need to talk to your surgeon about. But if you are just going to purely move the nipple, there's a risk of leaving a scar up straight up from the nipple, which isn't great. So that's a tricky one, Gemma. Amy, I better crack on with these. The dog ear removal after tummy tuck. Is there much of a recovery, or is it straightforward? Straightforward, Amy, straightforward. What was that? I've got an email. Could your team, that's a bit late. Could you or your team please resend your photo? Okay. Straightforward, Amy. I say straightforward, depends how big it is. Usually they're quite small. It's big, but usually they're quite small. Local anesthetic, waterproof dressing, dissolvable suture, in and out the same day. Um, might want to take the day off work, but back to work the next day, dressing off after a week, scars a bit red. There might be little residual dog ears and get the scar to settle. But actually, the procedure itself is usually relatively straightforward, Amy. Local anaesthetic, unless they're not really big ones, but that's usually something relatively simple to do. Makes the scar a bit longer is the only thing. So you have to accept the scar will be a bit longer and a bit red to start off with. Julie, have I missed the answer about breast reduction by liposuction? Um, you haven't missed it. I haven't said it. Is it on my? Yes, it's on my list. It's number 12. Number 12, Julie. It's on the list. We're on number 7 at the moment, but it's definitely there. God, what have we got here? Goodness me. Have I missed? Right, got that. Zoe, whoa, this is. I don't know what's happened. Oh, this is blimey. This is fame. This is. How long should it take for a muscle repair to stop hurting? So is it Zoe? Was it you that asked me about the year thing? Oh no, that was Rachel. I normally say it's going to be really sore to start. Well, no, actually, it varies. It varies, and when you do it, you put local anaesthetic in the rectus sheath and things like that. So hopefully it's not too bad. But by the tone of your question, I'm guessing it's hurting. So sometimes it can hurt a bit, and it can be a bit sore to start off with. And sometimes if you sort of bend over, you can take a bit of tension off it, or the tension takes more tension off the skin and the muscle repair. Muscle repair can be uncomfortable. So what I say, the first week is going to be pretty uncomfortable. Second week it might be better. Third and fourth week should be starting to get better. I really say things really start to settle down at 3 months. So I think after sort of 4 to 6 weeks, hopefully it will be getting better. But certainly at 3 months, I would really hope that things will be getting better. If it's really hurting at 3 months, in terms of if it's not getting better, then you think, hold on a minute, what's going on here? That's really unusual. So I'm going to say few weeks, Zoe. But if it's still hurting at 3 months, I'd say that's pretty not normal. Rachel, I asked for a lady in my group, so thank you. You're very welcome, Rachel. And I hope that she is okay. And I would say that I would get that investigated, Rachel. If it's pain for a year after tummy tuck, I would say that's something that she's first protocol going to the GP in case it's something else, and then the surgeon to see if there's anything else they can do. Ruth, hello, thank you. You're very welcome, Ruth. Thank you for asking the question. This is all about you, remember, not me. Steph, have you done surgery on someone with diabetes? I haven't got it, but thought it might be useful to know. Steph, that is excellent. Steph, I've got a question here about diabetes and tummy tuck, so I can do that. We can knock that one out. No, that was question 9. That was tummy tuck with type 2 diabetes. So thanks, Steph, for that. It's almost like we planned it. Have I done it? Yes, Steph. Of course I have. Done loads of tummy tucks on diabetes people. Well, I don't know about tummy tucks, but the diabetes is a common thing, and it's a bit like, do you remember that one we had the other week with autoimmune disease? It's a bit like that. Yes, you can do it, but you talk to your endocrinologist or your GP or whoever the person looking after your diabetes is, to make sure your diabetes is optimized, because we have these absolute and relative contraindications. It's not an absolute contraindication. It's actually, you can have a tummy tuck or a breast reduction or whatever it is if you've got diabetes, but you have got a higher risk of infection with diabetes. And so you've got things like tummy tucks and breast reductions, they have got problems associated with it, wound healing problems, infections, and that can be a bit of a big deal. So you will increase your risk of these things if you've got diabetes. So the first thing is to check that your endocrinologist, your GP, whoever's looking after your diabetes, is happy with you having surgery. And particularly if your diabetes is bad at the moment and your medications have been changed and they're trying to get on top of it and get your sugars better controlled, you'll probably wait until things are stabilized and as good as they're going to get. Once things are stabilized and as good as they're going to get, then you have to make a decision as to whether you are happy to take on the increased risks of surgery, given that you've got diabetes and you've got the increased risk of infection. And if you are happy with that, then discussion with your surgery, then you can have surgery, in my view. but you have got a higher risk, and but I wouldn't say that would mean you can't have it. You know, we had a patient, it's a while ago now, and she had a continuous pump of insulin. She had really brittle diabetes and was on a continuous infusion of insulin. So you can do surgery on people with diabetes, but you have to have a discussion with them, talk to the endocrinologist, and make sure everything's optimized before surgery. Great question there. How many reverse tummy tucks have you done, D? Hardly any. Single figures. It's not a big part of my repertoire. Last reverse tummy tuck I did was probably, I'll probably get it wrong, years ago, like many years ago, 3 or 4, I don't know, several years ago. Hardly ever do reverse tummy tucks, D. Pretty rare. I think so anyway. I don't think I've done one in the last few years, that's for sure. Yeah. So yeah, I guess I'm not the man for reverse tummy tucks. To be honest, I don't know if anyone is, D. I don't know if anyone does a lot of reverse tummy tucks. Not many people need it. You know, if you've got a bit of fullness here, you might want to do a bit of lipo. As I said before, not at the time of a tummy tuck, but reverse tummy tucks is a massive weight loss thing. Usually, when there's some fold, you've done a tummy tuck, and there's folds here. You know, quite big folds here, and then you make a sort of what's called a rooftop incision, which is underneath the breasts, joining in the middle, and you pull the breast up. So sorry, D, I haven't got a huge experience of reverse tummy tucks, but I've got to say, if you do a tummy tuck, it's similar to a tummy tuck, but it's just at the top end. I missed the last video. It's all right, D. It's fine. You don't have to watch them all, but thanks for being here tonight, as I would say, and commenting. Nice one. Rachel, nice one. Thank you. Junie, good to see you. Melissa, how you doing? Nice to see you. Melissa loves this man. All right. Which man? Zoe, thank you. I'm just over 3 months, but still sore. Yeah, that's bad, Zoe. Just over 3 months. Is it getting better though? That's the thing. If it's getting better, then I'd be happy about that. But if it's not getting better, I'll be thinking, oh, you know, what's going on there? But yeah. Yes, Steph, thanks for that. You are a mind reader. I'm very well because you did the type 2 one, yeah, diabetes. Good to see Melissa. Hi, Jonathan. Have you ever performed breast enlargement surgery on someone with an ileostomy? Not that I can remember. No, Lindsay, I haven't. I might have done. I don't. Not that I can remember. No, I'm not doing very well. I haven't done many times reverse tummy tucks. Haven't done it. But again, it's like anything. There's no problem with that. I mean, the ileostomy is quite far away. You'd isolate it. The only thing is, again, what's the situation with the ileostomy? What's the main thing that I would be worried about, Lindsay, is your nutrition. Is your nutrition up to speed? And are you, you know, if you've had it for years and you're stable and everything, then I would not if you're stable with nutrition, I would not worry about it, Lindsay. Yeah, I don't think I've done one. So if you're looking for a surgeon who's particularly done one with an ileostomy, to be honest with you, Lindsay, I'm actually doing less. Well, I'm actually stopping seeing new patients. To be quite honest with you, Lindsay, I'll come out with it. I feel like I'm an Alcoholics Anonymous here, and I'm sort of admitting something. Yeah, I'm stopping seeing new patients. I'm trying to build up my clinic, and I've got 2 other surgeons at the clinic, and I want to sort of build it up and be more of a. I want to get into the system so that we deliver a really good service to everybody, and I want to have processes and systems in place. And I find that it's difficult to do that and the surgery, so I'm going to focus on doing that and sort of supporting the other surgeons there. So even if I'd done loads, I would better. So I haven't, and so there you go. Maybe I'll never do a breast enlargement on someone with an ileostomy. But again, I don't think it's a bit like, well, I don't think you need to look for a surgeon who's particularly done that before. But anyway, if you are looking for that, then sorry, it's not me. Danielle, where you been? Where you been? Come on. Yes, I have done the tattoo. I've done the tattoo question. Not a great place for a scar, Danielle, up here. And the other thing is, when you have squirrely italic letters, I think most of the tattoo can be removed in one go. But there's a big squirrely italic letter somewhere at one end, and I think we might not be able to get all of that out in one go. So you might end up with a scar, with a bit of ink on either side. And the other thing I was saying is that it's not a great place for a scar. I don't know if you don't like the tattoo because of where it is, but the scar will be in the same place. So the other thing you might want to think about, because it's black and things, is like laser. I don't know if you've thought about that, but what we do at the clinic is excision, and that will leave you with a big scar. So is it worth it? So that's something to consider. But it's a doable, it's a goer, but it's not a great place for a scar. Yeah, okay. Okay, let's go. 7, right, we're back on the list here. 7. Do I need to bring someone with me if I have a procedure done at your see and treat clinic? I think there was more to that, wasn't there? Do I need a lift home? It's a good idea. It's a good idea to bring someone with you at the see and treat. And I think it can feel a bit weak and wobbly after a local anaesthetic. You think it's all going to be fine. Obviously, you sit and have a cup of tea and you rest and make sure you're fine before you go. But I think it is a good idea to have a sit down and have a cup of tea. And if you have got someone to bring you home, I think that's nice. So I think it is nice to have someone to bring you home. We have had people, get on the bus and things like that. If you have to, you have to. But if you've got the option, I think it is nice to have someone bring you home because you never know how you're going to react. And sometimes, you do feel a bit, Tummy tuck, high BMI. We've done that. Look at that. 7. Oh, hold on. Am I going the right way? I'm going the wrong way. Here we go. If you anyway, if you have a surgery, sorry, can I just go because Lindsay's come back here. Thank you for your answer. 4 years, no issues. Glad it wouldn't be a problem. Yep, Lindsay, good. I think that's the thing. It wouldn't be a problem 4 years ago. So you're stable with your nutrition and everything. So absolutely. Danielle, back in. Look at this. Back in. Come on. That's what we want. Daniel, I've had a laser over 5. Oh, right, but it isn't working, resulting in the tattoo going raised. That's it. It's a problem. Oh, you know what, Danielle? Good point. I should have said this actually. There's a certain area, and this sort of area is a certain area for keloid scarring. And that sounds like that laser is starting to scar you. If they go a bit deep with the laser, and if it's going raised, that's sort of like keloid scar, hypertrophic scar. And that, unfortunately, Danielle, that worries me because I'm thinking if we give you a scar, the scar might go raised. The whole big long scar might go raised. If you get a keloid or a hypertrophic scar, it's even worse than a normal scar. So you're in a difficult place there, Danielle. And the problem you often find is people who have laser, then it fades it, and then you can't relieve it then because it's a faded version of what it used to be. Difficult situation, Danielle. Difficult situation. I would worry that if we gave you a scar, it might make it a little bit. It might give you a hypertrophic raised scar. So that is a tricky one. Question 8 here now. If you have a surgery that isn't as successful as you would have liked, how long do you need to wait before having the surgery revised? Okay, a few issues here. First of all, things normally start to sell around 3 months. So 3 months is the absolute minimum. Depends on what the problem is. If the problem is something's way off and something's like really obviously not right, you don't want to leave anyone for a long period of time like that. So you do it as soon as possible. Often you'll find things that are not quite right and you're not quite happy with it, and there's a bit of a dent or a bit of a bulge or a bit of a lump or the scar's a bit this or a bit that, or one nipple's a bit higher or something like that. So in those situations, the longer you leave it, the better. So I would say 6 months, ideally a year. The longer you leave it, the better. The other thing you've got to think about is that sometimes the hospitals, the hospitals have a revision policy. So depending on, it can either be 6 months or a year or 2 years of how long they will cover you for revision surgery, i.e. you don't charge for it. So just be aware of that, because if it's like 6 months and you wait 8 months and they say, oh yeah, okay, I'll do a revision now. Oh dear, you'll have to pay now because it's 8 months. So just be aware of when the revision time is, because you might not want to leave it too long. But in my view, the longer you leave it, the better. That's why we do stuff at the clinic. I always say, look, I'll do it anytime. I'll do the revision anytime, because I'd rather you leave or wait a year or two, because you might not need surgery. I think it's a bit of a false economy saying to people they've got to have it done within a certain period of time. That's my view. But anyway, that's when you do stuff at my clinic. But if you do stuff at the hospitals, we're a little bit beholden to the hospitals' policies of what they say. Type 2. So now we're on question 10. I've got to keep track. I need a secretary here. I can't keep track what's going on. Danielle's done that. Rachel says, right, tummy tuck and liposuction together. If you have this done together, are you limited to the amount of liposuction you do? Not limited to the amount of liposuction, Rachel, but you're limited to the area that you can do. So I do the hips and the flanks, the side bits. So I don't do the top, the upper abdomen. Yeah. I don't do this bit here. I do these bits here, the side bits. So don't do these bits. So you're limited to the area that you can do, but not really the amount. You can still do an amount of time. That's just like timing. The time of surgery might be an issue if you're having a massive amount. But your eyes, right? Okay. BMI high, Nikki. BMI high, type 2 diabetes, PCOS. Is that polycystic ovaries? So difficult to lose weight on diastasis 7 centimeter. Whoa! Should I be put down? If I get BMI down, could I get abdominoplasty? Sorry, BMI high. No. Should we put down? No. Nikki. Nightmare. Really tough. 7 centimeters diastasis. I mean, that's a big diastasis, isn't it? If I get BMI, yeah. I mean, I think what you need to do is you sort of need to think of it when you're talking to surgeons about this sort of stuff. Sometimes what happens is you get into a sort of confrontational situation where you're saying, please, can you do surgery for me? And they're saying, no, you need to let your BMI go down and things like this. But actually, when you think about it, we're actually on the same side, because all this stuff, we want to do surgery, but we also want to get really good outcomes for our patients. And you're going to get a much better outcome if you can get I don't know, I'm saying this, I don't know what your BMI is, but if your BMI is high, you are going to get a much better outcome if you can get BMI down. If you get your BMI down, all the wound, you've got so many things going for you in terms of having a wound infection. You've got psoriatic arthritis, you've got type 2 diabetes, so you're overweight. So I think you've got a lot of issues there and sometimes people think, oh, doctor's not being very nice because they're doing all this. If a doctor did operate on you and you got a wound healing problem, they're not doing you a favor. So it wouldn't be doing you a favor by saying, yeah, so come on then, I feel sorry and I'll operate on you, because trust me, I've done it, and it's just not, you're not doing you think you're doing the patient a favor, but you're not doing the patient a favor. And at the end of the day, we've got to do what's right for you. And I think it's a big op, a tummy tuck, and when you get wound healing problems and things, it's horrible. It's horrible for the surgeon. For goodness me, it's much more horrible for you. So yeah, I think honestly you do need to try and lose weight, would be a thing if your BMI is high, particularly since you've got all those other comorbidities. You've got lots of reasons to get a complication, and you need to work closely with whoever's looking after all your arthritis and your diabetes, and if it is polycystic ovaries, PCOS, then that. So I'm a bit wary of these abbreviations. I've been caught out before with I was trying to catch me out, use funny abbreviations all over the place. Helen, could you have bigger implants 12 months down the line after breast uplift implants? Yeah, of course you can. Yeah, no problem. But I normally say minimize the amount of operations to your breast. Really, you don't want to keep on having operations to your breast if you can avoid it. So I would say if you were my patient, I would say, look, leave it as long as you can. See if you can live with them, because in 5 or 6 years or 10 years, that sounds like quite a long time when I say 10 years, but in the future you might need another operation if you get a capsular contracture or a problem, and then maybe think about changing it. But if you're absolutely desperate and you feel that you can't live with them, I mean, you've got to think. The other thing I say, when a lot of people say I want to go bigger with my implants, I say, look, you've got to go either wider or fuller projection, which is different, and you might not be as happy with the look of it. That's why we spend a lot of time getting the size and the choice of implant right first time. If you get it right first time, often people say they wish they'd gone bigger, but what they don't realize is bigger would either be wider or it'd be fuller, and therefore different. So just be careful what you wish for on that. So, but the answer is yes, as long as the implants will fit your frame. Can pregnancy have an impact on breast implants or breast uplift? Will they need to be done afterwards? Maybe. So if you said before having surgery, I'm thinking getting pregnant next year, we'd probably say to you, well, why don't you do that first and see how you go? If you've already got implants in, or if you already had a breast uplift, there's not a lot we can do about it because, all right, okay. So I just see how you go. When you get pregnant, you get breasts get bigger, you deliver the milk, and then they get smaller again, and sometimes they can droop. Sometimes they go smaller than what they were pre-op. Sometimes they stay big. So it's unpredictable what happens after breastfeeding. It might go back to normal and nothing might happen. You might be fine. So don't worry about it. If you've had a lift, there's a risk that you might not be able to breastfeed, although usually you can. But yeah, they can and they can be redone afterwards, no problem at all. You've got to be a bit careful about redoing a breast lift. You've got to make sure that the surgeon, ideally, have the same surgeon who did the first breast lift, or at least get the op note for the breast lift. Just because if you know redo breast lift is something you've got to be a bit careful about. Nikki, 39, too high. It's too high, Nikki. That BMI. I think you'll have a complication if you have surgery. But I haven't got any easy answers for you because it's really tough to get that down. But yeah, it is polycystic ovaries, is it? Okay. Can you have bigger implants 12 to 18 months down the line after uplift implants? We have that. So 275 360. Can you go from Polytech polyurethane to Mentor Smooth? Yes and yes. So 275 to 360, that's not a massive difference there, Helen. I don't know if you're going to notice a huge difference unless there's a dramatic difference in profile. Polytech to polyurethane to Mentor Smooth, yeah. Mm-hmm. Yeah, you can do that. Fine. Yep. Yep, no problem with that. Daniel, thanks for your feedback. Have you got any photos of example tattoo scars that you have done in the past for me to look at? Danielle, the problem with photos is that we get different levels of consent of the photos. What I'll say to you, if you come to clinic, and we don't charge for consultations for this sort of thing, so if you come to clinic, we'll show you photos there, but we haven't got, I don't know, there might be some on the website, but when we do photos, we say, do you mind us showing other patients? And do you mind us showing them on the website and things like that? So sometimes people might say, I'll happy for you to show other patients, but I don't want them on the website. So I'm not sure what's on the website, to be honest. I should check it, but you can have a look at that. But if not, we can certainly show you when you come to the clinic. And I know we've got a patient with a very similar tattoo, so we can show you that. You are the best. Thank you. Future husband, married. Okay. Oh dear, right. This is a big one here. Oh, blimey, all right. So people still up this time of night. Goodness me. Still up. All right, massive one here. You ready for this? Hands up if you're ready for this. I'm 70 years of age and I've endured large, saggy, painful breasts for years. Full breasts at age 11 and with a reduction 23. Proved to be an unmitigated disaster, leaving me scarred and lopsided. The surgeon removed 6 months of my medical record to hide his mistake, and the rest to show a successful 2-week stay in hospital, when in fact I was in hospital for 3.5 months and outpatient for a further 6 months. The female line of my family all have large breasts. Mine are still large, but now also scarred and painful. One of the nipples was cobbled together so badly as a sinus, still producing mucus in surgery at the age of 23. Over the years, the NHS have been reluctant to repair the damage done by one of their own. As a single mum, I never had enough money for myself, so I lived with these monsters all my life. I've now been able to save just enough for surgery, but I'm worried about my age and aftercare as I live alone. Am I too old? Wow. 23 to 70. Wow. God, what a nightmare. Okay. Answer to your question, no, you're not too old. We have operated on people in their 70s. And basically, if you're fit and willing, then you can have surgery. As I said a minute ago, revision breast reduction is a tricky one. And revision breast reduction, when you've had all these problems with your first breast reduction, is even more tricky. So I think you've got to be really careful, and you've got to think, you've lived all this time with it. Is it worth trying to get something done about it? If you've got a sinus, that sounds terrible. So it's tricky. I think you'd really have to consider whether it's worth taking on the risk of surgery this long down the line, because I've got to say to you, unfortunately, surgery can cause problems, particularly if there's a pre-existing sinus in there. You've got a high risk of getting infections and things could be contaminated, high risk of wound breakdown. You've got to, again, you really need the op note. So if you're 70 and you had it when you were 23, the chances of you getting hold of the op note are very, very slim. That's good in a way because the scar tissue would have grown some blood supply, but you've got to be a bit careful when you do a breast reduction because we isolate the nipple on a stalk of tissue, and you've got to use the same stalk of tissue, the same pedicle it's called, when you do the revision. So we don't really know what pedicle you had first time, so really tricky. And my advice would probably be erring on the side of leaving it, to be honest with you, because I think if you have a breast reduction, it might cause more problems than it treats. Although there's something you could have to think about yourself, and but that sounds like a bit of a tricky one. That one. Can side boobs be dealt with when having a lift stroke implants? Was there more to that? Does having a lift without implants decrease the size? Good, like this question. Yes. To the first one, side boobs. So basically, a lift and implants is one of the things it does. Obviously, it lifts the breast, gives more fullness to the breast, but it also narrows the breast because a lot of problems with people with large breasts is they're too wide. And when you do, or when I do a breast reduction, you try and maximize the tissue here, but you really empty it out laterally because you really want to empty out the lateral fullness or the side boob, as you call it. So that is actually an integral part of the operation, making the side empty and keeping the medial part full. So yeah, that is an integral part of it. Lift without implants decrease the size. Really good question. I don't know what the answer is. In absolute terms, it shouldn't really, because you only take a little bit of skin away when you do a lift, but you do take some volume away, and so you might feel that you're a little bit smaller. It's probably not going to be a cup size, but maybe a little bit smaller. Having said that, the tissue is brought up higher on your chest, so sometimes people feel bigger. So it's unpredictable what people feel about the size, but it's broadly about the same with a lift. Sometimes, you do take a little bit of tissue out when you do it. Right. Right. And amongst this, I've got a question. As I have looking through the comments. Right. We've got a question here. Okay. Got a question. Right. Professional. I'm a professional. Keeping noticed. That's my professionalism. Danielle, can you replace? Yes. Yeah. No. Then an implant fitted to teach us high shape. Wow. That's a pro question. That's pro. Is there something in there? That is pro. And you know what, Danielle? That's a brilliant question. That's gold star. You get the gold star for the best question. I shouldn't say that because all the questions. No, I'll retract that statement. They've all been brilliant. But that is a really good question. And Danielle, can I link that up with another question? But I've got to try not to lose my track. Where can you breast reduction by liposuction? I think we've done that. Oh my lord, what am I doing? So we've done side boobs, haven't we? So we've done it. We're on to 11. But I'm going to link that with this question down here. Here, this one. How do you know if you require an uplift with your breast enlargement surgery or not? So basically, breast uplift is for the shape. A breast uplift is for the shape. Implants are for the volume. So if you say to someone, what's the problem? Oh, it's the shape or the volume? Oh, it's the shape. I don't like the shape of them. Okay. Volume okay? Yeah, the volume's okay. Well, in that case, you have a lift. And if they say, well, it's actually the volume I don't like, I'm happy with the shape, I don't like the volume, implants. The problem is if you don't like the shape and the volume. So if your breasts are sitting low, to a degree, implants can take up the slack and can give volume to the breast. At the ISAPS meeting next weekend, I'm giving a talk about this. But to a degree, implants can take up the slack. They don't lift your nipples. They do give projection. They don't really lift your nipples. So implants are very good at giving volume, but they're not so good at addressing the shape. So if your breasts are a little bit droopy and you have implants, they might still be a little bit droopy, but they'll be bigger. And something we can go and show you photos in the clinic to see. You might think, well, I don't want that. I don't want droopy. But I'm like, well, look, this is all photos out of a bra. In a bra, they might be fine. You might be happy with it. But you might say, look, I'm not happy with that. I don't want to be droopy. Fine, not happy with that. Fine. Then you can have a lift. The problem with the lift is it does give complications, scarring, cost, nipple problems, potentially. So there are complications associated with a lift, but it does improve the shape. Now, sometimes if people say, I'm happy with the volume, but I'm unhappy with the shape, then they can just have a lift. and I show the photos of a lift. The lift goes like that first and say, yeah, I'm happy with that. You're like, well, wait a minute. In time, gravity works on them and they settle and they get a bit less full in the upper pole. Whenever you do a lift or a reduction, it starts like that and then it settles. And it gets a little bit less full in the upper pole, a little bit empty in the upper pole. So I don't want that. I don't want a bit. I want it full up here. And you can't really get persistent fullness in the upper pole by just doing a lift with your own breast tissue. That's when you need implants. And so sometimes people say, well, I'm happy with the volume, I'm happy with the size, because I've just said implants are good for size. Well, I'm happy with the size, but I'm not happy with the shape. But I'm also not happy with the, I want more fullness than the lift can give. And that's where this is what this people are talking about, which is taking volume out and then replacing it with an implant to give that fullness in the upper pole. That can be done. You can do that. You can take some volume out, put some, and people do that. Put an implant in to give you fullness in the upper hole. I don't like doing it. I don't like the concept of giving, taking away breast tissue and then you putting an implant in a prosthetic thing, you know, a foreign body to give that shape. Although if you feel that you're really not going to be happy without that fullness up there, an implant is the best way to give you the fullness. But personally, I feel uneasy by taking breast tissue out and then replacing it with implant. So I don't particularly like it, but it is a thing that can be done. So yeah, so that's a really good question. I hope I've given it justice there. So where was that question? For example, have reduction then implant? Yeah. I hope you. Sorry, did you answer my question about type 2 diabetes? Yes, I did. I did answer the type 2 diabetes thing, and it's fine to have it with diabetes, but you have to make sure you're stable with it. Talk to your endocrinologist, and what was the other thing? You will have a higher risk of complications, but we have to discuss that. Single surgeries or multiple? No, that's on my list. I still not answered that yet. I've got the single surgery or multiple on the list. Surely there'll be no questions for next week. We've done them all this week. How long on average do drains stay in for an uplift? Don't use drains for an uplift personally, Helen. Everyone's different, but I'm trying to use drains less and less these days, so I don't use drains in an uplift. If I did use a drain, which I don't, but if I did, I'd just leave them in overnight, bring them out the next day, take them out the next day. Right. Good to see you, Donetta. Nice to see you. Right. Cracking. I've been here for ages, Donetta. Absolutely ages. This has been crazy tonight. So question 11. Where am I? Can Saibu? We've done that one. Right. Do you perform liposuction to the breast with a reduction? Routinely, no. The thing about liposuction is whenever you do liposuction, you have to get the liposuction equipment out, and it's expensive. The liposuction equipment is expensive. So as soon as you open the packs for the liposuction, it's expensive. So you can do liposuction at the time of a breast reduction. Is this okay? Do you perform liposuction? Yeah, isn't it? Right, okay, we've got another question on the same lines. So you can perform a liposuction at the time of a breast reduction, and that's usually laterally to the side bits out here. Having said I take out the lateral fullness, I'm talking about the lateral fullness of the breast. So I take, obviously I haven't got a breast to show, but I don't know if this is showing, but I take the lateral fullness of the breast. If you have side tissue here on the side, then don't start, Donetta, don't start, please. If you have lateral fullness on the side chest wall, you know, where the bra strap is, that's where you can do liposuction, but it is an extra cost. So it does cost more. So you can do it, and it is an extra cost. So that's liposuction at the time of a breast reduction. This question is slightly different. Can you have breast reduction by liposuction if you have fatty breast and are postmenopausal? I'm not sure what the postmenopausal bit's for, but yes, you can have breast reduction by liposuction. But the problem with it, it doesn't remove any skin. So it's really for people who aren't a candidate for a big operation, because cosmetically it's not very good, because the people who need a breast reduction often have too much skin and their breasts are sitting low. And so if you just take volume out, you'll make them sit even more low. So actually it doesn't look very good. So it's often you need to tighten that skin, which is where all that scarring comes in, which is sort of lift part of it. A lift is part of the breast reduction. So you can do liposuction alone to the breast to reduce the volume of the breast, but cosmetically it never looks good, and it's only really for people with significant functional problems who can't take a big operation with all the scarring and things. Right, question 15. How many we got? It's 17. We're on 15, guys. We are doing well here tonight. How? Oh, I've done that, have I? How do you know if you require an uplift with your breast? You've done it. Oh, I don't know. Right, blimey heck. Right, okay. 16. How long off work for tummy tuck with lipo and breast lift, please? Um, how long off work for tummy tuck with lipo and breast lift? That's a lot to have. And then the next question, these are linked because should we do, and then someone else has said something about doing 2 operations. How long off work? Big, it's a lot to have a breast lift and a tummy tuck with lipo. That's a lot to have in one go, but it's perfectly reasonable. Perfectly reasonable. Um, I think I did. No, I didn't do that this afternoon. I did a similar thing this afternoon. But anyway, um, I'm going to say to you, the tummy tuck is probably going to be the thing that's going to knock you back. It's a bit sore, you're a bit all bent over for the first couple of weeks. You're not going to feel like doing anything for the first couple of weeks. After the first couple of weeks, you will be able to do stuff. So you might, if you work from home and work on the computer and stuff, after a couple of weeks, you'll be doing things. I would say something like 3 weeks, sort of average. You know, it's hard to be too specific about everybody, but 3 weeks for driving. So if you drive to work, maybe after 3 weeks, you'll be able to drive to work. But even then, you're going to not be doing anything heavy, taking it easy, no heavy lifting, stuff like that. Nothing heavy for 6 weeks. So I'm going to say 3 weeks off, 6 weeks, and then 3 to 6 weeks would be sort of light duties or phase return. And then after 6 weeks, you can start lifting and things like that. But you'd only be starting. You wouldn't be feeling great about it, but you could start trying to get into stuff. And then what we've got here, I'm going to do this one, I'm going to do Joni. Is it better to get done together or separate ops, please? Now, that's a good question. Who know? You know, some people have it together, some people have it separate. Doesn't mean that anyone's wrong. A lot of people want it done together because it gets it all done in one go, and your recovery is all just one recovery. So while you're recovering from the tummy tuck, your breasts are healing. So I can totally understand that, getting it all done in one go. But it's a lot to get in one go. It's a long operation. It's a long anaesthetic. You're battered and bruised, your tummy, your breast. You think, oh my God, I don't know if you're coming or going. So it is a lot to take on. And obviously, you've got potential complications in your tummy and your breast. So it's really up to the patient. But it is quite a common thing to do. They call it a mummy makeover when you have a tummy and a breast thing. So it is quite common to have it done in one go. There is a slight cost saving to have it done in one go because they do a discount on the cheaper procedure. It's not massive, but you know, so you just got to take everything into the mix. And it depends, if you just want one lot of time off, then I can understand why you want it done. But at the same time, if you can't face having it all done in one go, just have one done, and then maybe the following year have the other one done. So there's no answers really on that one. If you had lipo to side breast, could you remove much at once? What I mean is, could you remove it in one go? Yes, Junie. I don't know what when you say much. Have you got loads and loads and loads, which is really for a massive weight loss person. Then you might have to actually cut the skin out. Then that's so massive weight loss people. Again, lipo doesn't remove skin; it just removes fat. So you hope the fat recoils. So usually, if there's a modest amount around the side, sort of where the bra strap is, then lipo will do the job. But if there is an awful lot, you might think of extending the breast reduction out and doing an excision of that tissue. So yeah, it's a little bit worrying when you're saying how much can you remove a lot, because there's always a risk of the skin not recoiling. If you had breast lipo and lift, would it be less invasive than full reduction and less cost? If you have breast lipo and lift, well, no. That's a good question, Judy. Breast lipo and lift. It would be more cost because you'd be getting the lipo equipment out. So it'd be more cost than a breast reduction, and you'd be probably better off with just a breast reduction, because if you did a breast lipo and then you'd lift, then you move the nipple. You'd be moving the nipple, and you'd have been liposucking the nipple. So you'd be interrupting the blood supply with the liposuction and then moving the pedicle. So I don't think that's good. It's a good question, but I wouldn't do that. I wouldn't have breast lipo and lift. I'd just have a breast reduction. And no, it wouldn't be less cost. With type 2, is it best multiple surgery? No, but type 2 diabetes, you increase your risk of complications. So yeah, so it'd be more risk with type 2 diabetes. But again, you'd have to weigh it up, because you might say, I just want to go through this stuff once. But yeah, you're increasing your risk of complications by having 2 surgeries done and your diabetes. Yeah, skin as well, Junie. Well, then you're talking about a big op. Then, if you're talking about skin as well, then you're talking about an extended. You can extend the brachioplasty down onto the lateral chest wall, or there's all sorts of surgery. This is more like a massive weight loss type thing. So if you start moving skin, but obviously that means scars, big scars, big ops, big scars. Goodness me, Johanna, you are very welcome. I don't know about you, but flipping heck, that was a monster. That was a monster. I've done my 17. I think I've done them all. I terribly, unreservedly apologise if I missed any questions, because I went a little bit out of sync, but that's because I've got some live questions, which I love. I love the live one. I love the non-live ones as well. Don't want to make people with the non-live ones feel like they're not appreciated. Everyone's appreciated. Thank you very much. Thank you very much, everybody. I can't believe that that was so busy in there. I'm gonna go. Melissa, I think you commented. You've been a great commenter. I'm going to give you that. You've commented an awful lot, and you've contributed an awful lot. So I am grateful. I did say comment and share, didn't I? To be fair, I did ask for comments and shares. Didn't specify what sort of comments, but anyway, I'll take what I can get. So thank you, Zoe. Very kind. I will take what I can get. Good to have comments. So thank you, Julie. Thank you all. Thank you for asking questions. And I think this is it. I don't think I'll ever do another one again, because I've answered every question possible this week. But if I do get any questions between now and next week, let me think. What am I going to do? I thought I was going to be on time this week, to be honest, but I didn't realise I had to go out and have dinner with my son. He's having a bit of a hard time, so I'll have to go out for dinner. So I hope he's all right. Relax. Oh my God, right. I've opted for individuals. Good, Denise. Well, they'll see. I think that's not a bad idea, Denise, to go for individual surgery to type 2 diabetes, because, as I say, you're multiplying up your complication risks, right? 2 operations and diabetes and everything. I mean, it does mean 2 recovery times, but I think that's not a bad idea. It may not be right for everybody, but it's worked out for you, so that's excellent. So yeah, Dee, thank you. Thank you all. And yeah, as I say, if there are any questions next week, I'm hoping I'll be on time. I have no idea what I'm doing next week, living day to day. But 7 o'clock is what I'm supposed to be doing when I'm supposed to be doing it. And 7 o'clock next Tuesday. October, can you believe that? I can't believe it myself, but it is October. See you in October. Is it October by next week? Yes, it is. 2nd of October. See you then. Please do ask questions, and I will be. Look at this, Rachel. Straight in, Rachel. You're on a roll. I inquired about an arm lift with you, but I can't afford you yet. Can't afford me yet. What's that mean? That makes me sound. What? Can't afford you yet. Right. Okay. Well, I got. Rachel, it's a big op and arm reduction. It's up there with tummy tucks and things. It is a big op, but Kurum and Kurum will do the arm reduction things. He's not. He's a better price. Kuram. So I don't know if they told you about Kuram, but so. Gemma, I want a second opinion on my nipple. Can I contact you, please? Yeah, of course you can. Well, Gemma, yeah, I'm trying to do. You can certainly contact the clinic, Gemma. Definitely, you can contact the clinic. As I say, I'm trying to sort of ratchet myself down a bit from my clinical work and sort of seeing patients. I'm seeing my own patients. Definitely, I'll follow up my own patients forever. I never discharge my patients. But in terms of new patients, they're more going to sort of Kuram and Azam. Azam's a specialist in skin, so he's doing most of the skin work. But Gemma, you can definitely come, and I will be there. I'm there all the time, but whether it will be me, give us a ring. Give Lucy a ring, and she'll fill you in. Are you still operating? No, Danielle. I am still operating, but I'm still operating on people that I've on my patients. I'm not seeing any more new patients, Danielle. So, but my plan is to build the clinic up with other surgeons there, and they work with me, we work together, sort of thing, and we all work to the same standard and ethics and principles and processes, and that's my vision and goal for the clinic. I want to make it bigger than just me. I want to make it something good, and it's hard to do that while I'm operating. It's hard to operate and build a business that stands for something that's got processes and values behind it. So that's where I'm at. But Karan's a good guy. Karan's a really good guy. I mean, I know these guys, so they're all fully trained plastic surgeons, and then right. So anyway, there you go. 7 o'clock next week, Tuesday. Thanks again, everybody. Really grateful for everybody. I can't believe the support and the comments and everything. Fantastic. And I will be here at 7 o'clock next week. And please do ask questions on the Facebook or email or however you ask them normally. And because I'd love to answer some more questions next week. But probably next week I'll be back to normal, having a handful of questions and having to draw them out. Like what I normally do, but you never know. There might be some more questions out there to come, and so please ask away. And yeah, there we go. I'm going to sign off before it gets